चार्जिंग पे ध्यान देना, अगर ये निकल जाता है तो उसको हटा के वापस लगा दो। ऐसे में ये
Have you started?
yes, recording is going on.
Okay. Hello everybody. This is Yogeshwari Bansal. I am a master in optometry from Vinayaka University, and then I had done my bachelor's from AIMS, and I did my fellowship from L.V. Prasad Eye Institute, and I am a faculty. Currently, I'm practicing as a contact lens and low vision consultant at Eye Care Eye Hospital. So it's a great opportunity to share this presentation of whatever I know little bit about dry eyes and contact lenses. Dry eyes is becoming very prevalent nowadays, and the percentage as has been reported in many in literature it varies from 0.39% to 33% of the general population through self-reported symptoms of irritation, grittiness, pricking sensation, dryness itself. This has been seen, I've taken it from the article of .emj, Fondy, Richter D, Simpson T, and Caffrey B, Jordan D, in which a patient questionnaire approach to estimating the prevalence of dry eye symptoms presenting to optometric practices was taken care of, and hence how is they reached to this prevalence rate. So nonetheless, contact lens wearers also do complain of dry eye symptoms, and the article has shown that almost 50% of contact lens wearers do complain, if not regularly, at least occasionally. So these are the two articles which has been taken from this. So everything is literature based. Whatever I'm saying, there is a lot of literature available. So this article was by Gullian M, Stiles E, Gullian JP, Maisa C, which was published in Optometry Visual Sciences through preocular GFN characteristics of non-wearers and soft contact lens wearers. The second article was by Nicholas J.J., Michael G.L., Nicholas K.K., Shalmas R., Begley C. The performance of the contact lens dry eye questionnaire as a screening survey for contact lens related dry eye, which was published in Cornea 2002. So, the dry eye is becoming a new pandemic where, the causative factors for these dry eyes in contact lenses is both factors, environmental as well as ocular factors. Environmental factors, we all know air condition and computer environments are becoming a dry environments because of a constant work on the screen. Patients tend to have reduced blinking, and it all creates a dry environment. Even the screen users are apprehensive of it if they're not complaining of it. Sometime in future, everybody does feel like and complain of dry eye symptoms. Contact lenses itself is now has been recognized the major cause of dry eye symptoms, along with if there is a pre-existing dry eye. What do we need for successful contact lens wear? Contact lenses, as we know, is surrounded by a tear pool where you need a stable film, tear film. So the tear film has to be good, where all the constituents of three of its layers should be produced very well, and environmental conditions like dry environment, humid environment, whether it's allergic pollens in the air, so that itself will reduces the contact lens comfort. Even the contact lens parameters, like if it is a steep edge in a RGP fit, if it is a small dia in a RGP lens, they themselves also reduce the successful contact lens wear. Long wearing schedules, we know, can create hypoxia, and all these factors of ocular and environmental factors do cause dry eye symptoms in contact lens eyes. I call it contact lens dry eyes. Why? Because with contact lens, there is a reduced tear exchange, which is very well documented. There is a contact lens dehydration over a period of time, depending upon the water content of the lens, the modulus of the lens. So which leads to contact lens adherence, where a drying contact lens adheres or tends to stick to the underlying surface, cornea and conjunctiva. Is this contact lens dehydration does cause corneal desiccation, where there are and other corneal and conjunctival multiple inflammatory contact lens complications like CLPC, CLARE, these all do happen. So contact lens induce dry eye symptoms. This is the mechanism which is being followed. Reduced tear exchange, dehydration, adherence, desiccation, inducing other inflammatory contact lens complications. So contact lens giving rise to dry eye symptoms. Why? Because there is a constant friction of the contact lens with the bulbar conjunctiva, which leads to conjunctival metaplasia, means there is a overproduction or a malfunctioning of the conjunctival cells, which causes a reduced goblet cell density, which are present in the bulbar conjunctiva. Reduced goblet cell density means reduced mucin, reduced tear film interaction and binding with the ocular surface, because mucin is responsible for spreading the tear film, and henceforth reduced mucin means unstable tear film. So, which is what gives rise to dry eye symptoms. So, the second mechanism other than this unstable tear film is changes in the structure and production of lipid layer from meibomian glands. There is an altered thickness of the meibomian glands, right? The meibomian glands give rise to altered thickness of the tear film, because it could be atrophy of the meibomian glands, it could be that the meibomian glands openings are blocked. So both kind of picture will give rise to there will be altered reduced thickness of the tear film. As well, along with the thickness, even the osmolarity of the tear film does change, because it could be more lipid or debris in the tear film, so less water. So increased osmolarity, tear film osmolarity will give rise to unstable dry tear film, which will give symptoms of evaporative dry eyes. The third mechanism is corneal glycocalyx reduction. Corneal glycocalyx is a glucoprotein which help to protect the corneal cells against mechanical and chemical damage. Since it's a hydrophilic barrier, and the reduction of corneal glycocalyx will invite more friction during blinking and maintain since it's responsible for hydrophilicity, lesser corneal glycocalyx will cause the dry eye symptoms. So these all mechanisms give rise to what has been reported as a Clyde and CLD. Clyde is contact lens induced dry eyes, but of late CLD, which is contact lens induced discomfort, has been termed in 2013 by the International TFOs, which is Tear Film and Ocular Surface Society. There is a lot of articles by the TFOs. TFOs has done a very good job, and there are lot many literature is available which we can go through. So TFOS has described CLD. That is what we'll be talking in my further presentation, that contact lens, rather than contact lens induced dry eye, we call it contact lens induced discomfort. So this has been described as episodic or persistent adverse ocular sensation related to lens wear, either with or without visual disturbance, which resulting from reduced compatibility between the contact lens and the ocular environment. Very aptly said. So, I mean, this covers it, describes it very well. So, contact lens discomfort, or how does it affect the patient or the eyes? As we said, that 50% of contact lens users are complaining of this CLD, so that is how it reduces your comfortable wearing time. So the patient who was able to wear it for 12 hours, which I personally feel any lens should be comfortable for 10 to 12 hours at least. So the CLD will give rise to reduced wearing time, and eventually it will be a cause for contact lens dropout. As over the years, as we see, the contact lens technology has gone leaps and bounds, but the number of contact lens patients, percentage of wearing contact lenses has not gone up. That is, and because of this CLD. So there is a 50% dropout currently, which is a very high percentage, whether they are going for refractive surgery or there is a most of them complaining of CLD. So 50% dropout of contact lenses is there. Out of which, when we see 50% dropout, mainly it's the soft contact lens wearers. But I have been seeing in my practice even the RGP dropouts as well. There was a time when soft lenses had swiped RGP lenses, but the RGP lenses came back into action with, rose K for keratoconus and other corneal degenerations and many scleral. So when there is a RGP dropout, then we have nothing else but then many scleral lenses, which itself is a lens mentioned for Stevens-Johnson basic dry eyes, is what which has been prescribed. So when we talk about CLD causing contact lens dropouts, this is what I was saying, that the contact lens dropout has been a major challenge to the contact lens practitioners, and the CLD has been recognized as the main cause for contact lens dropout. So what do we need to do when we are doing contact lens discomfort examination? Patient visit. So first you have to do these 5 things, right? We always emphasize on regular aftercare, slit lamp examination of the patient for cornea, conjunctiva, but for CLD, along with cornea and conjunctiva, we have to look at the meibomian glands function. So meibomian gland function is through their, the orifices which we need to look at it. Other than meibomian glands, it's the lid margins. So lid viper epitheliopathy, which is called LWE, has been recognized as a new thing for CLD. Other than these two, we definitely have to look at the lid margins to look for any meibomitis blepharitis, any conjunctival and corneal staining, and we have to do tear-film breakup time. So let's go in detail. Meibomian gland dysfunction, it is again a very prevalent in the general population, it goes 3.9% to 21.8%. It is a major cause of discomfort in the eyes. And believe me, the treatment itself will make patient feel so happy. And it has been observed in females more. That doesn't make much difference to me, whether male or female. But meibomian gland dysfunction is definitely going to cause evaporative dry eyes. So the diagnosis of MGD and its management is very important. So let's see this small video on it.
Most things, the spectrum of gland health is broad. But what we have learned recently is it's not just the appearance of the gland that identifies it as being healthy. Traditionally, we have thought of MGD as an infectious disorder that shows signs of inflammation. However, in a 2010 paper, Blackie and colleagues coined the term non-obvious obstructive MGD. When evaluating these eyelids, they look healthy and normal. But it's not until you apply pressure to the eyelid that you realize that something's wrong. What you see is that nothing or very little comes out of the glands. We believe that non-obvious obstructive MGD may be a precursor to traditional or obvious MGD. Please please realize that we are attempting to downplay the way that the eyes look and focusing on more what's happening or how they're functioning. We have seen great looking glands be totally non-functional or not flow at all, and conversely, bad looking lids can be very functional. Of course, if the lid looks bad, even if the gland function is good, we may want to treat the inflammation. In either case, we believe that it's critical to get glands that are obstructed to flow again. Otherwise, these glands will shut down. The glands will atrophy and ultimately disappear, and the patient's symptoms of dryness will increase with time. As we mentioned in our previous clinical insights, we feel that it's critical to express the glands in order to identify the number of functional glands and the quality of the secretions that they release. It's best to apply the pressure with an instrument that puts a constant pressure on the eyelid, like the MGE from Tear Science. If you don't have this device, we suggest placing a light amount of pressure on the eyelid with the thumb or forefinger. And may we stress light. Just like most practitioners, when we use our thumbs or forefingers to express, we find ourselves applying significant pressure to get the glands to express, as if we're single-handedly going to cure the patient from MGD with a firm pressure. May we assure you, applying this much pressure does nothing more than give you a meibomian gland show in your slit lamp. Applying a light amount of pressure or a known or constant pressure with the MGE is diagnostic, as it represents the best case scenario of what your patient applies to their own eyes when they blink. If you ask us, we think you should use the MGE. As described in our prior episode, we suggest if you see less than 5 glands that are yielding a liquid secretion, you should look at treating, because we know that glands that do not flow will deteriorate and ultimately disappear. We're going to do an expanded clinical insight in our next episode in order to share with you how we approach the treatment of patients with MGD. Just because a patient does not have symptoms of dryness or because their glands look healthy doesn't mean that we shouldn't treat them. Synonymous to glaucoma, a patient with low pressures does not mean that we don't have nerve damage. And if they have nerve damage, you certainly would look to treat them, even if you have no symptoms. MGD is no different. Look for Clinical Insight 17. Like most things, the spectrum of gland health is broad.
So next to this video, let's go to lid viper epitheliopathy, which has been recognized of late. What it is? It is a windshield viper effect on every blink. The under surface of the upper lid is called the lid viper, and due to this constant friction of the contact lens with the upper lid under surface, we do get this lid viper epitheliopathy. So on clinical examination, on the vital fluorescein, sodium fluorescein staining, beyond the line of marks is the mucocutaneous junction. So beyond that, this is marginal and this will be palpebral. One will see here it is marginal staining, and then it's very common to see the lid viper surface epitheliopathy. So if you have this will be one reason for your contact lens discomfort. Blepharitis is another reason which can cause more of unstable tear film by changing the osmolarity or evaporated dry eyes. We all know it's very simple to diagnose blepharitis, which is a deposition of white flaky stuff. There are multiple types of blepharitis. I won't go into that detail. We know the treatment for blepharitis: lid cleaning, lid hygiene, and then supportive treatment. Next to that is the conjunctival and corneal staining. Again, that on which we get these two both with soft and RGBs. On every visit, clinical examination is very useful. That patient, you have to see the patient without the contact lens, stain it, and wait for the reinsertion. The record keeping of the staining, of where it is and how much grading it is, 1 to on a grading on a scale of 1 to 4, whether it's the icon has divided your zones 1, 2, 3, 4, 5. So which zones are having and how the patient is following up. I mean, whether it's increasing, it's due to the solution toxicity or the corneal desiccation. So, I mean, that unstable tear film. So look for the reasons and treat the cause. The next is the measurement of your tear film breakup time. I mean, it's very obvious, low tear film breakup time will cause unstable tear film. So let's see this small video on it. So 5 seconds, less than 5 seconds, definitely low reduced tear film breakup time. So other than this clinical examination, we can do an objective analysis of the tear film also through different instruments which are there, very much popular nowadays. These are, I mean, LipiFlow by the name of LipiFlow through Johnson Johnson and ocular surface analyzer. We are having these two instruments in our institutional practice and finding it very useful to differentiate, to diagnose which type of dry eyes, and then the treatment effect over a period of time, the progression, rate of progression or improvement. So very useful. Other than these two, as a routine, we do the Schirmer test, which measures the basic aqueous secretion and the tear meniscus height. So even these two instruments also give your objective analysis of your tear meniscus height. So how do we manage contact lens discomfort? Yeah, very much important management, regular aftercare of every contact lens patient, examination of the eye as well as the lens to look for deposits, any cracks, disposability of the lens, how old the lens is the patient changing the lens regularly or is it delaying it, and conjunctival corneal staining, and then looking for conjunctival allergy, other than, as we said, tear film breakup time and Manrobian gland dysfunction. So you have to examine, diagnose, and then treat each collectively or separately. The standard treatment of contact lens discomfort will be to increase your lens disposability. If a patient is wearing conventional, shift them to monthly disposables. Somebody wearing monthly, change them to 2 weeklies, then weekly, and then if still the discomfort persists, then go to daily disposables. Daily disposables will be those lenses having a high surface water content will be preferable because that will increase the wettability and the low modulus. right? If we have the option of, because the higher water content lenses will demand more tear film and indirectly will cause contact lens dehydration. So if it is a high surface water content but basic content is low, that will be better. Other than that, I mean, in collaboration with the cornea doctors, we can prescribe preservative-free lubricants along with the contact lenses. Other than, if your patient is off the contact lens, then you can give sodium hyaluronate, which is more viscous than carboxymethyl cellulose. Carboxymethyl cellulose also comes into percentages 0.1% and 0.05%. So you can choose according to the symptoms and the tear film breakup time, which one to give. Preservative-free on-tear units are supposedly performing very well because there is no preservative associated toxicity. So on a long run, these disposable or a single unit tears are much better, which can be easily used with the contact lenses. Gentle eye drops are better because although they are preservated, but when you don't have the options of units, then you can give for a short while. Although, I mean, if it is a disposable lens, it's not going to keep the preservative much in the bag. So, but with the contact lenses, avoid sodium hyaluronate and fresh liquid gel type medications because it goes too viscous with the contact lens, it can hamper your vision. So, thank you so much for your attention. I'm reachable at this more number, and you can, for any Q&A, you can mail me at this is my mail, Yogeshwari @icarehospital.org, in the capacity of working as a departmental head at iCare Eye Hospital and Postgraduate Hospital in Noida, UP, India. Thank you so much, everybody.